Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me. Have you ever wondered about bipolar disorder, if you suffer from it? Many of you have actually been formally diagnosed with this condition. Perhaps bipolar type 2? Have you ever been prescribed mood stabilizers? Are you wondering if you really need them? If your diagnosis is correct and why you aren't feeling much better? If the answer to any of these questions is yes, then stay tuned. In this video, I'm going to tell you about the syndrome of bipolar disorder. How bipolar disorder is not a single illness, but a group of conditions. How the diagnosis exists, like so many do in psychiatry, on a spectrum. And how, in the United States, bipolar disorder is vastly overdiagnosed. I've been in practice nearly 30 years, and I've seen it for myself, firsthand. I could cite one source or another about the incidence and prevalence of bipolar spectrum conditions, according to epidemiologists who can't agree. The numbers vary wildly. But whatever these stats, in my own considerable experience, and many of my colleagues will agree, bipolar disorder diagnoses are far too common. Meaning, manic depression, which is the same thing, is being diagnosed when it shouldn't be. Patients are being prescribed medications for mania, which is the sine qua non, when they aren't experiencing mania. And inasmuch as all of those mood stabilizers can be toxic medications with very serious, even potentially lethal side effects, at therapeutic doses, mind you, not an overdose, but at regular doses, people who don't need to be on mood stabilizers shouldn't be exposed to them. Now, albeit the really dangerous side effects are relatively rare, but inasmuch as these dangers do exist, we shouldn't prescribe them lightly. And there are other side effects that may not kill you, but we don't want patients to gain tons of weight and develop metabolic syndrome and tardive dyskinesia and all of these other potentially permanent problems that are serious side effects and not uncommon. And there are different classes of medications that serve to stabilize the mood, which means preventing and settling down mania. Okay? Stabilizing the mood means treating mania. Patients with manic depressive disorders, bipolar disorders, suffer from both recurrent depressive as well as manic episodes. And some mood stabilizers happen to also be pretty good antidepressants, especially for those individuals who actually have bipolar disorder, such as lithium and the second and third generation antipsychotic agents, medications like Zyprexa, as well as the partial dopamine agonists, meds like Abilify and Vraylar, etc. These are often used in augmentation strategies to treat resistant unipolar major depression, so not as mood stabilizers. And I have videos on all of these, but the sine qua non of bipolar disorder is manic or at least hypomanic episodes. If those don't occur, then it's not bipolar disorder. It's really that simple. What's not so straightforward, apparently, is how to evaluate for the presence of true mania. When I first started practicing, after a 4-year residency training program in psychiatry at Southwestern Medical Center in Dallas and certifying with the American Board of Psychiatry and Neurology, I would see patient after patient carrying a diagnosis of bipolar disorder that had been made by another practitioner, and the diagnosis was wrong. The patient didn't meet criteria for bipolar disorder because whatever else was going on, they had never experienced true mania. They'd been told they had bipolar disorder, some of them for years, and they had received treatment with variable results, some good, some not so great, but they did not, in my estimation, suffer from those illnesses. And I'm using the plural because I'm referring to a spectrum of conditions, each one of them a syndrome. Many of these patients have been diagnosed by several practitioners. I remember one patient challenging me one time, and rightly so. Patients should question their providers, asking, "Are you telling me that all of those other doctors were wrong?" She'd been treated for well over a decade, and I had to tell her, yes. The problem is that a lot of practitioners become prejudiced by the history. Patients will announce their established diagnosis, and doctors will accept this pre-applied label and just go with it, instead of making their own independent evaluation. The diagnosis just gets carried forward as part of the history taking. And especially if patients report doing well on their mood stabilizer, the doctor accepts that at face value and just refills their lithium. It's the path of least resistance, right? Why fix something that doesn't seem to be broke? It is broken. Diagnostically, it's broken, but nobody knows. And things seem to be going okay. The patient's taking medication they don't need, that they really shouldn't be taking because maybe they've gained a ton of weight on it, or it's making them really, really sleepy, or it's giving them other side effects that can be potentially very serious, but they're blithely taking it and they think that it's helping them. And they think they have bipolar disorder. And all of that is wrong. And that scenario is extremely common. It happens all the time. And it's not just lazy practitioners. Other, perhaps more well-meaning but busy and distracted clinicians might do the same, especially non-psychiatrists, general practitioners, or family practice doctors who don't feel that they're in a position to question a, quote, established diagnosis, especially not one outside their field, made by a specialist. And the longer a patient remains on treatment and the more providers they see, the less likely it is that a single practitioner at the end of a long line of practitioners is going to refuse to honor that diagnosis or decline to continue that treatment plan. But especially if a patient sees a lot of different practitioners over the years, the line just gets longer and longer and the diagnosis more and more entrenched. And so that's how that happens. It's not that the diagnosis is that obvious. It's just that it becomes increasingly incontrovertible. Additionally, a lot of the time, disabusing a patient of an erroneous bipolar diagnosis is difficult because the patient is convinced that lithium or Depakote or some other mood stabilizer helped them feel better. The medications seem to work, and many patients are loath to part with the diagnosis itself. Never mind the treatment, it unsettles them. No one wants to be chronically misdiagnosed, for one thing. That's bad news that nobody wants to hear. So that's alarming, but also for some patients, the label explains things. So at least now they have a reason for their intense emotions and their problematic behaviors, an explanation, even if it's wrong. Ironically, for some patients, it can be a relief to be diagnosed because then they know they're not losing their mind or that it's not all their fault. Sometimes it's hard to convince people to set aside a diagnostic label because the label itself serves a purpose. And then many improve after being started on mood stabilizers. But first of all, it could be a coincidence. Maybe the patient would have gotten better anyway. Secondly, there's the placebo effect, meaning the patient got better because of attendant psychological factors related to the fact that they knew they were taking something expected to help their mood problems. And beyond that, even if the medicine truly did settle things down and confer something of an antidepressant effect, which many of those medicines do, even for patients who don't have bipolar disorder, a positive response to medication certainly doesn't give us any diagnostic information. You can't go backwards and verify a mental health diagnosis because a medication that happens to be FDA approved for that illness helped. It doesn't work that way, especially not in mental health. Lithium and Zyprexa and those medications can also be helpful to individuals who do not suffer from bipolar spectrum illnesses. So that's a separate topic that I talk about more in my course on bipolar disorder. Now, stabilizing the mood means assuaging and preventing mania, not elevating the mood during a depressive phase. That's antidepressant efficacy. Some clinicians might disagree and argue that stabilizing can mean not letting the mood dip into depression as well, but I think it's better to understand that mood stabilizers are best reserved for patients prone to manic episodes, or at least mixed episodes that include mania, i.e. dysphoric mania and depression occurring at the same time, and usually a lot of anxiety, maybe some irritability, so the patient doesn't feel euphoric, but their mood is elevated in addition to also experiencing depressive symptoms, negative thinking, and that sort of thing. Time and time again, I've seen patients who complain of quote-unquote mood swings placed on mood stabilizers. They have a labile mood, an unstable mood to be sure, but there's never any mania, and so it's the wrong medication, usually. Again, there are serendipitous exceptions, as when the medicine unintentionally helps with the depression and the clinician thinks that it's functioning as a mood stabilizer. Some are good augmentation strategies to add to a regimen for recalcitrant depression. Here, I'm referring to using these medications as mood stabilizers. Maybe the patient didn't need augmentation because the antidepressant was working just fine, even though they felt a little better with the addition of lithium. Or maybe they truly did need greater efficacy and they weren't at remission yet, but the antidepressant just needed to be increased to achieve better remission. The antidepressant monotherapy wasn't at the maximum dosage, so why add an augmentation strategy if you can just increase the dose? That's always a preferable strategy. Minimizing the number of medications in use avoiding polypharmacy. And so the patient felt better, but not because the medication is stabilizing the mood. Even if their mood swings did get better and their agitation got better, it wasn't mania, but it got better because you're now using a serotonergic agent, a partial dopamine agonist, say. But now everybody thinks that, oh, well, we added a mood stabilizer and they got better, so that they must truly have bipolar disorder. They're working backwards, verifying the diagnosis based on a reaction to treatment, which is always wrong. And they thought maybe the patient had bipolar disorder. They added this medication, the patient got better. It's just a big morass of confusion because we're not properly identifying target symptoms and we're not looking for true mania and we're working backwards. There are a lot of pitfalls. There are a lot of missteps. I talk about them all in my course on bipolar disorder. Adding a mood stabilizer, even when it does help, was the wrong move in those cases, and especially if it appeared to corroborate a false diagnosis. In those cases, the clinician is treating a diagnosis instead of correctly identified target symptoms. I talk about all of this in deep dive detail in my new curriculum on the overdiagnosis of bipolar disorder. Please check it out. My premium content at notonanemptymind.thinkific.com, which includes a syllabus and a series of exclusive videos for individuals who are wondering if they or a loved one truly suffer from these conditions, or if it could be something else. How to just about rule it out in yourself before you go see a mental health provider. That is possible for most people. My course is no substitution for professional opinion, obviously, but mania can be ruled out. If you've never experienced it, it can be ruled out easily by a layperson, just like you can rule out migraine headaches if you never have headaches. If we know what migraine headaches are, we know what they look like, we know what they feel like. Well, it starts on one side of the head, and a lot of times it generalizes to the other side. And if there's an aura and you feel nauseated, or maybe you see flashing lights and you gotta go into a dark room and it really hurts. If that has never happened to you, if you're one of those people who has never had a migraine headache and you can definitively say right away, and you hear that and you say, no, that's never happened to me, not anything close to that. Yeah, everybody gets headaches, but I've never had anything even close to that. Then you can say, I am not a migraine headache sufferer. It's the same thing with mania. It's not always severe, but it's so extreme, it's so out of the norm, it's such a departure from a person's baseline, and it's got very specific symptoms that if you know what true mania is, if someone can teach you that, then you can just run through the symptoms and you can say with clarity that no, you don't have that if you've never experienced anything like it. All patients should go see an expert to have confirmation, but those of you who can rule it out, just like you can rule out migraines, you've saved yourself a trip to the psychiatrist because you know firsthand that no, it's impossible. The sine qua non is mania. Hypomania, which is even milder than mild mania, it's a little mania, is that much more subtle and difficult to discern. And that's why it's very much overdiagnosed by those clinicians who've never seen full-blown mania in action. When you've seen mania, and then you see all this other agitation that people are having and all these mood swings they're describing, then you know that's not that. It's not that thing that I've seen over here that is due always, 100% of the time, to an aberration in brain chemistry. There's something wrong with this person's brain. And this person over here, they're having all kinds of problems and they're having all kinds of emotions that are unmanageable, maybe problematic behaviors, but it's not because of an excess of catecholamine neurotransmitters. It's a different animal. Unfortunately, doctors and patients don't know how to communicate about these symptoms a lot of the times. A lot of people have been subject to conflicting opinions and indeterminate evaluations, along with perhaps more than one ineffective medication trial, and really could use some clarity and peace of mind. So to that end, I offer a couple of services. But first, if you haven't already viewed it, please check out my 3-part video series on the overdiagnosis of bipolar disorder. Part 1, Nowhere Near Mania, can be found on this YouTube channel. The link is in the description below, and you'll also see it at the end of today's presentation. And if you're interested in Part 2, True Mania, that's also available free of charge at my private online academy, Not on an Empty Mind. So please check all of those out. They contain great information. It's a great curriculum. If you want more individualized help, I do offer private, non-medical, one-on-one consultations, coaching sessions. They're non-medical because they don't involve establishing a doctor-patient relationship. I don't formally examine or diagnose my clients who live outside of Texas, where I can't practice medicine. But obviously, I bring my experience and expertise to bear in answering any and all questions you may have for me. So please feel free to schedule a consultation. And also, you can enroll in my academy free of charge if you want to be placed on the mailing list for special offers and future freebies, including exclusive videos on a variety of topics that you won't find here on YouTube. So please consider signing up. There's a lot to know about bipolar disorder that's simple to understand. You don't need scientific or medical training to get it. Laypersons are capable of understanding and applying it to their situation. Bipolar disorder is a spectrum from not having it, i.e. not being on the spectrum at all, let's not forget, to a condition called cyclothymia, followed by bipolar disorder type 2, and then full-blown manic depression on the opposite end, bipolar disorder 1. These are endogenous conditions. They have to do with physical illness, endogenous, meaning arising from within, born from within. Aberrations in neurophysiology. There's something wrong with brain chemistry. They're syndromes, so we don't have a single etiology for all of them. Most of the time, we don't know the root cause at all. And similarly, we can't assume a universal pathophysiology, which, again, hasn't been well elucidated for most of them. The best theory involves an excess of the catecholamine neurotransmitters dopamine and norepinephrine for whatever reason. If we dial these up by taking street drugs, for example, we get mania a lot of the times. And so patients with bipolar spectrum conditions just develop mania sometimes because of too much dopamine. They're not reactions to life. That's the important thing. The mood disturbance comes first, then the reactions. The emotion, then the behavior. And that's true most of the time for most of us, just day to day. Please check out my Primordiality of Mood two-part video series. Obviously, major mood episodes are not a choice. They're not a weakness or a character flaw. They're no one's fault. And this is, again, why some patients cling to these diagnoses, and they require medicine, period. This is medicine, not psychology. So keep that in mind as I discuss this spectrum of bipolar disorders. Cyclothymia is a condition characterized by distinct episodes, recurrent periods, of hypomanic symptoms and depressive symptoms for at least 2 years, 1 year for children. In cyclothymia, symptoms are typically mild. Hypomania means less than full-blown mania, a little mania, limited symptoms that are attenuated. And although symptoms must always cause significant distress or impairment in daily functioning in order for us to say that they amount to an illness that requires treatment, whatever that treatment looks like, whether it's medication or not, they don't meet the full criteria for another major mood disorder, including and especially bipolar 1 on the other side of the spectrum. Cyclothymia is less often diagnosed because, for one thing, it's more subtle, and so if anything, it's underreported, it's missed by practitioners. Cyclothymia is not overdiagnosed. And for another is that it's far less famous. It may not even be on non-mental health providers' radars. If they never think about cyclothymia, maybe they heard about it in medical school, but they never think about it, they don't read about it, no one's talking about it, there are no commercials about it, then they're not going to pull it out of their little bag of diagnoses and apply it, especially not primary care. A bit further along on the spectrum, we have bipolar type 2, which is frequently diagnosed, in my opinion, far too often. I have the feeling that a lot of bipolar 2 labels are punts. The clinician is punting, where they're not completely sure the patient has bipolar disorder. They think maybe they do, and so they diagnose bipolar 2 as a sort of compromise. Diagnosis should never be the product of uncertainty. If we diagnose type 2 bipolar disorder, we should be confident that the patient meets diagnostic criteria for that disorder. You providers in training out there, take note. If we make this diagnosis, we should be sure that the patient is indeed experiencing hypomanic episodes, or we should at least believe that that's the case. If we think the patient may suffer from a bipolar spectrum illness, but we're not sure, then we continue observing and evaluating. And in the meantime, we prescribe medication based on confirmed target symptoms, be they what they are, not some diagnostic paradigm. And we refrain from potentially mislabeling a patient and adding to that legacy of misdiagnoses. You can really hurt a patient. It can last for the rest of their lives if nobody catches it. And it's really, really hard to undo the psychological damage. If you've believed that you've had bipolar disorder for years and years, it's really hard for a clinician to debrief you. At any rate, again, we treat symptoms, not diagnoses, but we shouldn't use the bipolar 2 diagnosis as a cop-out because the clinician is unsure about bipolar 1. If the clinician feels it needs to be maybe ruled in, the first step is not to diagnose a milder version. I hope that's clear, because I do get the impression that that happens sometimes. And I think it's because when there truly is no mania, right, a practitioner can convince themselves that, well, maybe it's hypomania. I don't really see it, right, because it's not there. But I don't know, the patient's complaining of mood swings, the antidepressant isn't working. Maybe it's hypomania. Bipolar 2, because they can't justify bipolar 1, but they're unsure, and so they downgrade. But it's a misdiagnosis. And so with bipolar type 2, the risk of misdiagnosis is greater for that reason. It's harder to diagnose bipolar 2. And I think bipolar 2 is uncommon. I myself have diagnosed it a handful of times in my entire career, thousands of cases over the decades, and I very, very rarely have diagnosed bipolar 2. So, when I see patients being diagnosed bipolar 2 right and left, and when one clinician has a whole catalog of patients, they all have bipolar 2, most of them probably don't have any bipolar disorder. They're not even on the spectrum. So I'm extra skeptical when I see bipolar 2, and I'm always skeptical of a bipolar diagnosis. I have to be. These conditions are overdiagnosed, and as far as I'm concerned, it's not bipolar disorder until it's proven, no matter how many years of carrying that diagnosis and being treated for it. The treatment can be toxic, so we don't consider those diagnoses when we're conducting our own independent psychiatric evaluations. We must look for true mania, confirm true mania. That's the task. Does the patient experience manic episodes or not? You as the patient can help your doctor. Meet them more than halfway, as I like to say. Arm yourself with knowledge. Go in there knowing, if you're really not sure, knowing that, well, all of this that you might think is bipolar is not. And you can learn that in my course. I teach it. So I'm skeptical, and you patients out there should be too. If your practitioner tells you that you have bipolar disorder, make them prove it. Even if you think that you do yourself, make sure that they're certain. Or at least, if they're not 100% certain, that's okay. We're all human. Ask them, how certain are they? That's a good question for a provider. And here I want to make a quick aside to remind viewers about my 60-plus questions you should ask your psychiatrist. A must-read for consumers of mental health treatment involving psychotropic medications. A digital copy of which you can download for free by visiting my online academy. There's lots of good stuff over there. Please check that platform out. The link is in the description below. Please sign up to receive special notices and offers. There's no obligation. But I'm extra leery whenever I see bipolar 2. Getting back to the spectrum here. I've disabused hundreds and hundreds and hundreds of individuals of their bipolar labels. Taken the diagnosis away, and not always easily. As I've said, some patients are very reluctant. And I was only wrong a handful of times. But I was right all those other times. Hundreds and hundreds of times. It's not difficult to rule out bipolar disorder. It's much harder to properly rule it in, but ruling it out is fairly straightforward. Obviously, you can't diagnose yourself. Obviously, you can't definitively arrive at a diagnosis. But if you've never had a migraine headache, then you know that you're not a migraine headache sufferer. And so most of you out there, the vast majority of you out there that don't have bipolar disorder, because the vast majority of people don't have it, can do that for themselves, if they know how. The actual stats are all over the place. They vary widely depending on the source, from the World Health Organization to the National Institute of Mental Health. Respectable authorities who can't agree. So that right there tells you that there's something wrong with these statistics. Why can't we accurately measure the true incidence like we can for certain types of cancer? Because of rampant misdiagnosis. Those estimates are pretty useless. Does it really help if I tell you, if you want a ballpark figure that I more or less subscribe to? I would say it's close to, but less than 1%. So I think it's less than 1 out of 100 individuals. 1% is the established prevalence of it. It's 1% prevalence, so 1 out of every 100 people on the planet right now. But there are estimates that are more than double that. And so what's that about? The accepted is 1%. In my book, it's less than that. But again, that doesn't help you clinicians out there. All you do with that is, this patient probably doesn't have it. And that's what you should think. Every time a person walks through your door, you always rule it out. But because of that incidence, even if we go with the stat of 1%, now, there's a selection bias. If patients come into a psychiatrist's office, it's not the general population, so it's going to be more than that percentage. But still, most patients don't have it. Each case must be evaluated individually. And my particular bias is that it's probably not. Bipolar 2 also involves depression and hypomania. It differs from Bipolar 1 in that there's only hypomania. The mania never gets full-blown. The distinction between Bipolar 2 and Cyclothymia is more subtle because they both involve hypomania and depression. But Bipolar 2 is further along the spectrum, typically involving moderate or more severe symptoms, and it's defined by the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, which is published by the American Psychiatric Association, with more specific time criteria. So the hypomanic episodes have to last at least 4 days each, and they alternate with major depressive episodes that last at least 2 weeks. The mood swings that we see in cyclothymia are less severe and shorter in duration than for bipolar 2. This is kind of nebulous, and so cyclothymic symptoms are sometimes described as hypomania-like and depressive-like symptoms, whatever that means. Some of these diagnostic paradigms really are pretty nebulous. At the end of the day, it doesn't matter what we call it. I'm always saying this. What matters are the symptoms, and that's another video as well. The diagnosis is important prognostically, but clinicians should always focus on what's in front of them when they go to prescribe treatment. And finally, bipolar 1 disorder, or simply bipolar disorder, is next, with full-blown manic and major depressive episodes, and it's on a spectrum of its own, a spectrum of severity, from mild to severe, with the latter form potentially including psychotic symptoms such as delusions and hallucinations. For example, delusional grandiosity, which is a form of paranoia. It's grandiose paranoia. Most cases don't include psychosis, being out of touch with reality, but some do. So if you've ever had any encounters with these diagnoses or their treatments, and you want to learn everything you need to know about this topic, including how to rule it out in yourself, always conferring with a professional, of course, for confirmation, but arming yourself with a lot of knowledge beforehand that will help you help them not diagnose bipolar disorder without confirming the presence of true mania, then please check out my deep dive, part of the premium content you'll find at my online academy, Not on an Empty Mind. Thank you, and as always, questions and comments are welcome.